emergency medicine consultant in United Kingdom. I'm here with Dr. Prager, who is an intensivist and internal medicine specialist, who is here with us to talk about venous congestion. Over to you, Dr. Prager.
Hey, thanks for having me, Nick.
Yeah, no, thank you so much for being with us. I think this is a very topical concept, and it's going to be very exciting to talk about this. So please, if you would like, I know that you've got a great presentation for us to go through, and we'll go through, I believe you've got the background of venous congestion as well as 3 cases, and we'll make it very interactive and ask you questions and bring it to a close and have some discussion. And I'm sure after this talk, we'll have some questions from the viewers as well.
Absolutely. And I should say that in Canada, I'm living in London, Canada, not London, England, but we have a Thames River here too. So, I mean, I feel like we're kindred spirits right from the get-go here. So, yeah, thanks again for having me and just looking forward to the discussion here. Yeah, so I'll hop right in.
Yeah.
I think the first concept to start with is the concept of renal perfusion pressure. And every organ really has a perfusion pressure. And this is represented by that inflow pressure, but also the outflow pressure. And in the brain, we're really comfortable with the concept of elevated ICP and cerebral perfusion pressure, but the kidney has a perfusion pressure too. And loosely, this can be defined as kind of the pressure going in the map and the pressure going out, or the central venous pressure. And if you're in the ICU and the patient's map drops down to 50, we're very, very quick at defending that map with fluids and vasopressors and really restoring that back to kind of whatever target. Venous pressure increases from, say, 5 to 15. We don't have that same degree of kind of alarm bells going off in our head, and we're not intervening on that right away. And it's important to say that the pressure going into the kidney is not actually the aortic pressure at like 100. The pressure is actually these smaller arteries and arterioles going into the kidney. So the relative change in venous pressure is actually probably more significant relatively to the pressure actually supplying it. So you could see very easily how a CVP going up from 5 to 20 can very, very quickly cause organ dysfunction, particularly acute kidney injury. And this is one of the reasons why elevated central venous pressure is consistently associated with acute kidney injury. So this is septic patients, and as the venous pressure starts going up, your risk of new or persistent AKI goes up as well. This has been studied in larger kind of ICU cohorts, kind of tens of thousands of patients. And one of the interesting things is maybe in patients with low systolic blood pressure, this effect is even more pronounced, which again makes sense because it's a higher relative amount compared to the map if your map is lower, the effect of venous pressure. But the problem is that the sensitivity and specificity for CVP to predict acute kidney injury is actually quite poor. And this was shown in that original VExUS paper that we're going to talk about more. So the question is, why does CVP fail? Like, why are we going to talk about venous congestion, Doppler, and VExUS and all that? And there's a couple reasons. So the first is that the pressure at the right atrium doesn't necessarily predict or measure the pressure at the kidney. There's other pressures at play, intrathoracic, intra-abdominal pressures that can complicate this. Additionally, some patients might actually need a high CVP to maintain forward flow. Think about that patient with pulmonary hypertension. So just because your CVP is 12 or 14 doesn't necessarily mean that's pathogenic. We really have to go to the organ level itself to really understand the impact of venous congestion on organ dysfunction. And this concept is not new. It's been around for decades. Some of the early work was with kind of the group in Montreal, André Deneau and the rest of his colleagues there. And one of the things that they found is that there's certain markers like portal vein pulsatility that can actually predict acute kidney injury after cardiac surgery, with portal vein pulsatility fractions of above 50%, resulting in increased kind of odds of acute kidney injury. This has been studied prospectively now with multiple different Doppler markers. So again, taking a look on the left here, portal vein pulsatility above 50%, it has an increased hazard for acute kidney injury. And then looking at actually now the renal veins or the intrarenal veins, these intrarenal vein flows that are normal have a lower hazard for acute kidney injury. And as they become more severe, the hazard gets higher. And so this really led the group in Montreal to think, well, how do we combine all these different markers of congestion? We have IVC, we have portal vein, we have hepatic vein, interrenal vein. Can we combine them together to make a score that is really a multi-organ assessment of venous congestion? And this is where the VExUS score came out. And I just want to pause here and say that VExUS is really just a scoring system that was derived in a cardiac surgical population and has been studied in some other populations. But it was really derived in a cardiac surgical population. Venous congestion Doppler are the individual markers that represent congestion. And so there's certainly still questions about what threshold should we be using. Is the VExUS score validated in different populations? Absolutely. But the concept of venous congestion has been around for decades, even if the VExUS score itself is a more recent development. And that's something I feel like sometimes gets kind of overlooked there. Now, when we quantify somebody with the VExUS score in the traditional sense, it ranges from 0 to 3, with scores of 2 or 3 representing congestion. And so the more abnormalities you get, the higher your score and the higher the association with acute kidney injury. And for the hepatic vein, normal is kind of this systolic greater than diastolic pattern where below the baseline here is forward flow. As we start seeing some mild abnormalities, we notice that the systolic wave is now less than the diastolic. And then eventually the systolic wave actually becomes reversed. And that reversal represents severe congestion. For the portal vein, it starts off kind of very smoothly continuous, maybe mildly pulsatile. As we start getting above 30% pulsatility, we start seeing kind of mild congestion. And then as we start getting above 50% or even reversal in the portal vein, that represents severe congestion. And then the last is in the interrenal venous Doppler, we see the smooth continuous flow below the baseline. That's normal venous flow. Above the baseline here, this is an arterial tracing because the small arterioles run adjacent to the interrenal veins. So you capture both the signals at the same time. But below the baseline is actually what we're interested in. And this is the interrenal venous Doppler. And we start seeing it become this kind of biphasic, where there's this interruption in flow and there's actually no venous drainage. That's abnormal. And then eventually you get this monophasic pattern where you only have draining of the kidney during a diastole, and you have large periods where there's no venous flow. That's severely abnormal. And so how did VExUS compare with CVP? And so what we can see here in these kind of leaf plots is that on the right is CVP. So this is if you have a positive test, what is your post-test probability? And it changes from, say, this point up to this point. And yeah, there's a little bit of a change, but it's not nearly as strong as if you have a positive VExUS or a severe congestion. You see a much greater change in the post-test probability that the patient will develop acute kidney injury. It's been studied in the ICU. So venous congestion and VExUS has been studied in the ICU with abnormalities in the hepatic vein and portal vein associated with acute kidney injury. So what actually causes venous congestion? And this is just another diagram of what we talked about before. And I'll just go through it one more time here, because I know that when I was learning venous congestion, it certainly is not intuitive initially. So as we start seeing more and more congestion, we start seeing kind of the systolic wave in the hepatic vein become less than the diastolic wave. And then eventually that can reverse and actually combine with the atrial wave here. So you don't want this to and fro kind of blood should be moving forward for the most part in our body. It shouldn't be kind of coming backwards to an equal velocity or an equal amount as it's going forward. That's typically quite abnormal. The portal vein itself starts off very smooth, starts becoming pulsatile, and eventually you can actually get reversal of the systolic wave, which again, just conceptualizing that, blood has to go backwards from the right atrium into the IVC, into the hepatic vein, through the hepatic sinusoids, and then reverse into the portal vein. That's crazy congestion. With the renal vein, it starts off continuous, and then it goes to this kind of biphasic pattern where there's these brief interruptions between the waveforms, and then eventually you get this monophasic pattern where most of the time there's no venous drainage. This is actually captured in something called the renal venous stasis index, which is essentially what portion of the cardiac cycle is there no flow. And if your renal venous stasis index is high, like 0.6, 0.7, 0.8, it means that most of the cardiac cycle there's no venous drainage. That's bad. And you can see that that's a nice way to kind of make this ordinal scale continuous if you're researching it or studying it. But I want to make a point here. And that point is that venous congestion is not the same as volume overload. And this is something that I think gets equated a lot and potentially has harmful effects for patients, because the treatment of venous congestion is not diuresis. The treatment of venous congestion is really figure out why they have congestion. It would be like if you saw B-lines in the lung and you're like, oh, B-line is pulmonary edema. We know that there's non-cardiogenic pulmonary edema, there's cardiogenic pulmonary edema. It could be protein, it could be infection, it could really be anything causing the B-lines in the lungs. Our job is to figure out what the cause is. And even if it was cardiogenic hydrostatic pulmonary edema, not all of those are benefited by diuretics. For example, if a patient has a mitral valve prolapse because of an MI, and they have like a flail mitral valve with severe MR, the treatment is not diuresing them. Yeah, you can temporize them with some diuretics and afterload reduction and positive pressure, but you got to fix the valve somehow. And so similarly, when you have a patient with venous congestion, just because the organ's being congested doesn't mean that the treatment for that is definitively going to be diuresis, as we're going to see. And part of that, I think, comes from this really simplified concept of venous congestion in our mind. And the simplified concept is high rate atrial pressure goes into the kind of IJ and the IVC, and then that gets transmitted to the kidney. But that's really just the textbook answer. That's not actually what happens in real life. And definitely a shout out to Abhilash Kortala for POCUS for his awesome diagrams as per usual. And if anyone wants to learn more about venous congestion, I highly recommend kind of starting there. But venous congestion is really multifactorial. You have the cardiac function, so patients with RV systolic or diastolic dysfunction, elevated PA pressures, pericardial disease like pericardial effusions and tamponade, tricuspid regurg can all cause congestion. The treatment of some of those might be decongestion, but it could be inotropes, it could be drainage of the effusion. It could be pulmonary pressures. So patients on positive pressure ventilation, particularly with higher PEEPs, can have worsening kind of organ level congestion. Pleural effusions can actually affect the pressure gradient and cause organ congestion. So I've seen cases of large pleural effusions with severe congestion, and you drain the pleural effusion, and immediately the renal congestion actually improves. IV fluids definitely can contribute to congestion. So right now, if you hooked me up and gave me 10 liters of IV fluids, I probably wouldn't develop severe congestion because I have, hopefully, I haven't had an echo, but hopefully a normal heart and no cardiac pathology. And so I would be very fluid tolerant. But you take that patient, that heart failure preserved ejection fraction patient with chronic hypertension, diabetes, and you give them 10 liters of fluid, they're much more likely, because of that interplay between the heart and the volume, to develop severe congestion. And then the last thing is things like intra-abdominal pressures. If somebody has renal edema, IVC stenosis, this can all cause congestion. And so I think my kind of biggest take home from this is that when you see a patient with congestion, you have to ask the question why. And it's probably an interplay of multiple different factors, similar to when you have a patient with RV failure. You don't say, oh, they have RV failure. Great. The question is why? Is this afterload related? Is it ischemia? What's the actual underlying etiology of that RV failure? And I think this is something that, because venous congestion is a new concept, is sometimes missed, particularly as people are learning it. So I just really want to double tap on kind of this point. And then a couple just points here, and then I think we should open up this discussion a little bit more. So first is how can we use venous congestion? There's a lot of different ways. So it can be very helpful to differentiate between congestive and hypovolemic acute kidney injury. It can be used as a marker to titrate diuretics during kind of cardiorenal syndrome or heart failure. Could it be a stop point for IV fluid resuscitation, potentially for a patient with sepsis, for example? Could it be a start point for somebody with deresuscitation? A start point for deresuscitation in a patient with congestion? Is it a marker of occult RV pathology that requires investigation and treatment? And then is it a prognostic indicator where patients with severe congestion may have worse courses in the ICU, and we could use this to inform discussions with family or loved ones or patients?
Okay, thank you very much. That's sets the scene very nicely, and it is on a simple level. I suppose if we're talking about the tissue or cellular level, what we're talking about is that as the Starling law kind of dictates, that fluid shift can then be impaired, and the cells cannot function as they can. And as you rightly said, there are so many different confounding factors in there that we need to bear in mind. So taking VExUS score on its own it will help. However, we need to put it all together with the lungs and the heart. And I think the other aspect of it, which I've appreciated more, is the liver as well. So, for example, if there's a patient who's got portal hypertension, for example, or other, for example, portal thrombosis, those can affect your measurements as well. So that it is very important that as you've rightly pointed out, you really have to think more widely, and VExUS is one piece of puzzle within trying to figure out what's exactly going on. And as you rightly again said, the venous congestion is not to do with fluid overload, but rather what's not functioning normally within the series of mechanisms you have, and what you need to do going forward to try to fix that. So thank you so much for that. I think I suppose the other questions to do with this is it was very interesting to see some more recent papers looking at SVC. What are your thoughts on doing measurements on SVC, as well as the other parts of the VExUS score that we've talked about?
Yeah, great question. I think the SVC is attractive compared with the IVC for a couple of reasons. So the first is that you don't have intra-abdominal pressure kind of impacting it as much. It's measured more proximally to the right atrium. But I guess in my mind, I would wonder whether or not the SVC is really just a really great marker of right atrial pressure. And one of the benefits I see to measuring venous congestion at the organ level is that it doesn't matter what the your kidney doesn't care what your right atrial pressure is. Your kidney cares whether it's congested, yes or no. And it doesn't care whether or not it's congested because of intra-abdominal pressure, whether it's congested because of tricuspid regurg, because it's RV failure, volume overload. Your kidney that has severe congestion is congested. That is like a ground truth for the kidney when it has monophasic pattern. And so I think that understanding maybe the congestion status at the kind of right atrium might help you figure out which of the causes is contributing, because maybe it's totally normal at the right atrium and your SVC looks really normal. And then you look at the kidney and the kidney is severely congested. So you're like, oh, maybe there's something kind of below the diaphragm here that we need to investigate. But I think the problem in my mind is more about we want organ level markers of congestion for the most part, at least in my mind now. And one of the things we're noticing in our Andromeda VExUS study, which is a multi-center observational study looking at venous congestion and septic shock, we're recruiting at 20 centers worldwide, looking at this as a sub-study of Andromeda Shock 2. And one of the things that we found is that patients have patterns that don't fit VExUS score at all. You have a patient with a collapsed IVC and severe renal congestion, and a normal portal vein and a mildly abnormal hepatic vein. And in the traditional model that we have for venous congestion using the VExUS score, that doesn't make any sense. And so I think there's still a lot of things we don't understand. And that's why I love looking at the kidney in particular, because if the kidney is congested, the kidney is congested. You can kind of almost discredit the rest of it. And the rest of it in some ways might help inform the etiology of the kidney congestion, but it doesn't impact the fact that your kidney is congested.
No, that's absolutely really great point there. That end organ pressure is so important, and that's not a that would be a great marker. It either is or isn't, and I suppose going back to the VExUS score, I think as you say, there is a lot more work to be done, and there is a lot more research to be done to find out about how can we use it more widely, because as you say, the initial paper as well was on cardiac patients with renal failure, and can that be generalized to the rest of the population, rest of the specialties, and also the rest of the board as well. And I suppose the aim would be to have a more comprehensive score whereby you can integrate the cardiac side of it as well as the lung side doing the longer studies and put it all together. And perhaps with certain patients, you can pick out part of that score and do that first, and that you might not need to do the whole of the scan, as it were. So thank you so much for that. I think we'll move on to the cases next. Is that right?
Yeah.
And we'll sort of discuss a bit more at the end.
Absolutely, yeah. So the first case here is our very kind of bread and butter kind of medicine or emergency or ICU case. So you have a patient that presents to hospital with fatigue, abdominal distension, dyspnea, and leg swelling. They have some mild orthopnea. They're not having any kind of paroxysmal nocturnal dyspnea or waking up in the middle of the night gasping for air. I'm not sure. What do you guys call that in the UK? Is that how do you say that?
Well, we just call it PND or orthopnea as well, and
Okay.
we usually measure it with how many pillows do you sleep on, or do you wake up in the middle of the night opening the windows, for example. That's how we, yeah.
I love it. I love it. And so this patient, they have a history of some heart failure with preserved ejection fraction. We can see that their echo here kind of shows normal LV function, but the RV is kind of severely dilated with moderate dysfunction, kind of chronically. There's mild TR. They have an elevated RVSP. They're on some heart failure medications here. And so we diagnose them with an acute decompensation of heart failure that seems to be more right-sided than left-sided because they're not on a ton of oxygen and they have chronic RV dysfunction. And so what we start doing is we start diuresing them. And lo and behold, their weight starts getting better. But also what happens on the right here is their creatinine starts going up. And this is Canadian units, which I think is the same as the UK. But for American listeners, this is a creatinine of, I think, like 1.5 or 2 or something. In the American units. And so the creatinine starts coming up here. And somebody inevitably asks, could this patient be intravascularly dry? And we see this all the time when we start diuresing people and start decongesting them, that the creatinine goes up. So do you stop? Do you double down? And these patients can be really hard. Sometimes it's obvious that, yes, we need to keep going, or it's obvious that we need to stop because their edema is completely resolved. But I find that you throw in a bit of low albumin in there can really start being a question about somebody's true intravascular volume status. And I find that VExUS in this situation is just so useful. So we look at the IVC here, and the IVC is really plump and dilated. And when I look at the IVC for venous congestion, I don't measure it. I don't look 2 centimeters or not. That was the original VExUS score, sure. But what I try to do is I look as much of the intrahepatic IVC as I can. Like, I look at all of this and I try to make a judgment. All right, does this seem like it's kind of collapsing? Yes, no. Is it like 20% collapse, 10%, like roughly in my head? And I just assign a label, plethoric or not plethoric. I don't go any more than that. And part of that is measuring the IVC in long axis is really flawed. The IVC is not a round structure. If you put in a central line and internal jugular or femoral, unless there's severe elevated right atrial pressure, veins are like collapsed ellipsoid structures. And so the IVC also has that kind of view in short axis. So when you look at it in short axis, you'll find that it's actually an ellipsoid, but it doesn't always sit kind of like in a horizontal plane. It could be like diagonal, it could be vertical. And so really, I think you have to look at it both in IVC and short axis and long axis, and look at multiple courses throughout the intrahepatic IVC to make a global assessment of whether you think it's dilated or not. And that's something we're actually doing as part of Andromeda VExUS, and we're looking at it in short axis. And we have some cases where the IVC looks like it's like 3.5, 4 centimeters in long axis, but when you look at it in short axis, it just so happens that it's totally collapsed, but it's vertically aligned. So when you incinate it through the long axis, it looks really, really big. It's fascinating. But I think it's something that more and more evidence will come out that maybe short axis is a valuable way to do it. When we look at the hepatic vein here, we see that there's kind of, so this is the atrial wave, and how I know that is there's ECG cables. So atrial systole is right here. So this is our A wave. Systole here, kind of QRS complex is right here. So this is your S wave, which is very, very small. And then this is your D wave because it's in diastole. So this is an S less than D. So kind of congested pattern, but maybe not severe as reversal. But you could see that a tiny bit more congestion here, and this is going to easily pop up above the baseline. So this is probably pretty significant congestion. When you look at the portal vein, I promise this patient was not in ventricular fibrillation. This must be an artifact down here. But you can see that this is clearly above 50% pulsatility here. So severe congestion, and we have some velocities up here that would confirm that. You could do, for example, maximum minus minimum over maximum. So 19.5 minus 6 over 19.5, probably like 70% pulsatility or something like that. And then we look at the intrarenal vein. And when we look at the intrarenal vein here, we see that this is the arterial tracing above the baseline. So, and then below the baseline, you see kind of this diastolic flow here, and it's monophasic. So this has answered the question, is this patient hypovolemic or still congested? This patient still has severe congestion. So in fact, we kept going with the diuretics and increased the diuretics. And so we reassessed the next day. And we can see here that the IVC is still kind of looking a little bit plethoric, but maybe not quite as big before. We look at the hepatic vein here, and what we see here is, so again, I find the atrial systole, which is kind of right here. So this is our A wave. There can sometimes be a little bit of a delay between atrial systole and kind of where the A wave is, because it's like arterial / cardiac versus venous. So A and then S for systole here, which is less than the diastolic here. So this is still abnormal, but it's maybe not quite as bad as before. We look at the intrarenal vein, and we see now that we're no longer monophasic, but we're in a bit more of this kind of biphasic pattern with brief interruptions here. And then we look at the portal vein, and there's still some pulsatility, maybe 30, 40%, but it's not nearly as severe as before. So it's getting better, but there's still renal congestion, there's still hepatic congestion. Let's keep going. So we keep going here, and now we can kind of look at the IVC, and all right, we're starting to see maybe a tiny little bit of kind of collapse. I don't think I'd call that totally collapsible, so I'd say still probably in the plethoric range. But kind of looking here, now we see a normal hepatic vein. So this is, we don't have ECG here, but this is the A wave, S. You can get this little kind of wave between S and D called the V wave, which is a tiny bit of a reversal wave here. So ASVD, but normal. All right. Portal vein is much less pulsatile. And now we look at the kind of venous Doppler below the baseline here, and we see that that's continuous now. So this patient's congestion has gotten better. And so really, when we look at the weight here, we kind of paused at day 4 before, but the weight kept going down, and then the creatinine started coming down too. And we see this, that the creatinine lags 24, 48 hours behind what's actually happening at the kidney. And so if you're basing your diuretic strategy based on creatinine alone, I think it will often lead you astray. And one of the things that one of the things that I've learned and has been discussed in the literature is that creatinine can increase 30, 40, 50% in response to diuretics without it being necessarily bad or pathogenic or that you need to stop diuretics. And so it's like when you start a patient on an ACE inhibitor and their creatinine goes up a little bit. As long as it's not above a certain threshold, that's actually normal, and that's part of the physiologic effect of the medication. And so I don't kind of worry about it too much, so long as I'm demonstrating then the patient still has congestion. So when I start seeing that creatinine going up, instead of just cutting the diuretic dose or holding it or giving albumin empirically, I actually just look to see whether the patient's still congested. And maybe we've already resolved the congestion, and then we could back off on the diuretic, or maybe there's still severe congestion, or maybe the congestion's even getting worse, and we need to go up and up and up and add more and more, or maybe support the RV or do some other therapy. So really my take home from this case is that venous congestion Doppler can help guide ongoing decongestion, even in the presence of a rising creatinine, and hopefully answer the question, could this patient be intravascularly dry?
Okay, thank you so much. That's an absolutely brilliant case. It's a classic case that we see time and again. And when I was working in medicine, we saw it. When I was doing my rotation in critical care, we saw it. And I suppose my question is that before you had this VExUS as a tool, what would you have done? What would have happened? So let's say you didn't have access to this. What, given that the creatinine is going up and up and up, what would you have done? It would have been just a tossing of the coin and 50-50. Are we going to continue with furosemide? Is that a wise thing? I don't know. Or would you have started filtering the patient? I'm not quite sure. What would you have done before VExUS?
Yeah, I mean, even with VExUS, I think the approach is still kind of the same. We're integrating clinical findings, history findings, exam findings, ultrasound, blood work. And so I would really start with the history. Are they still dyspneic? Are they still symptomatic from it? From an examination perspective, do they have peripheral edema still? Do they have other markers of left-sided congestion perhaps? Maybe they have some pleural effusions, a bit of pulmonary edema, oxygen requirements. What about their other blood work? BUN, creatinine, are they hemoconcentrating their hemoglobin? We're looking kind of for a holistic marker. We could do an IVC ultrasound. You could get a formal echo and measure your E over E prime to look for kind of left atrial pressure or like left atrial filling pressure. And I think that's still what I do. I want to emphasize that we're not basing this patient's decongestion based on VExUS alone. It's one helpful tool, and certainly in this case, it featured a prominent role in it, but really you're integrating everything together as we do with clinical medicine. I think whenever we use point of care ultrasound in isolation to justify decisions without the clinical context, we often get led astray. And so even though certainly I'm a POCUS supporter and researcher, and it's what I love thinking about and spending my day doing, I always want to go back to the patient to really kind of start there, as opposed to starting with the POCUS finding and then working the way back.
Yeah, that's a brilliant point there, because I often get asked to perform a POCUS scan on a patient that I've not seen, and my first question is actually, let's start from the beginning. What's happened? And most of the time, I've become selective as to who I scan, because it can actually raise more questions than answers, and I kind of have to pause and think, well, what are we trying to get in here? And as you rightly say, this is a piece of a puzzle. But yeah, no, thank you so much for that case. That's absolutely brilliant. So shall we move on to the next one?
Absolutely. So this next patient, this is a common case that you see in the emergency department, ICU, or medicine ward. You have a patient that has septic shock because they have bad pneumonia, and they get admitted to the ICU, and they've received about 3 liters of fluid in the emergency department, but they have ongoing hypotension. They're hypoperfused with high lactate, poor cap refill. Maybe their oxygen requirements going up. So the question is always, do we give them more fluids or vasopressors? And so there's a lot of different ways to kind of approach this and solve this. And it depends on a little bit what paradigm you're using to approach this. So some people would adopt the fluid responsive paradigm. And fluid responsiveness is just, if I give a patient a fluid bolus, will they increase their stroke volume or cardiac output, depending on who you ask, but stroke volume or cardiac output by 10 to 15%. And somebody would say, well, hey, if they are fluid responsive, we should give them more fluid because we want to fill them up to the maximum kind of amount we can. But I find that sometimes the fluid responsiveness approach ignores the potential harmful effects of IV fluids. And we know that beyond just venous congestion, fluid overload is an independent predictor for mortality for critically ill patients. It can cause damage to kind of glycocalyx, endothelial dysfunction. It leads to kind of immobility in the ICU, wounds, infection, a whole bunch of breakdown and problems for critically ill patients. And so the other side of that, instead of thinking what are the benefits of fluids, is what are the harms of fluids? And that question has been termed fluid tolerance, or how will my patient potentially be harmed by fluids? And fluid tolerance is really influenced by a couple of things, but the first thing is their acute illness. If you have a patient with, let's say, heart failure that comes in, they're not going to be fluid tolerant because they have acute decompensated heart failure. We all know that. It could be their chronic comorbidities. If you have a patient with an EF of 5% and is on end-stage renal disease with dialysis, I wouldn't want to be giving that patient 5 liters of fluid. And we all kind of intuitively know that they're not going to be tolerant to fluids. But then I think you can also integrate venous congestion into that equation. So you can start asking yourself, what are the benefits of IV fluids with fluid responsiveness, but what are the harms of IV fluids? And venous congestion can play a role in that. And so we actually studied septic shock at our center in a 75 patient pilot. And this was some of the basis for Andromeda VExUS. We actually found that early on, so this is like ICU admission, about 20% of patients were congested. And that when you look at their status on day 3, there's about 15%, but some of the patients that were congested initially became not congested, and some of the patients that were not congested became congested. And we don't really have the numbers to really kind of explore that in great detail, but it's a dynamic process that's present early on during somebody's septic shock course. And we're seeing similar things with our Andromeda VExUS pilot data as well. Our Andromeda VExUS data. And hopefully when we analyze this, we'll be able to kind of really explore what the natural history of venous congestion is. But there was an excellent paper published recently I can't remember who the first author was, but Eduardo Coutan, Glenn Hernandez, and kind of the team there. And what the paper looked at was in patients with septic shock, or sorry, in patients in the ICU, what percentage of overlap is there between fluid responsiveness and congestion? Because often we think, well, if somebody's fluid responsive, they can't be congested. But it turns out actually these two things can exist together. So for fluid responsive patients, which is not the majority of ICU patients, and this is something that's really important, most people, when they get admitted to the ICU or on the hospital ward, are actually not fluid responsive. But the patients who are fluid responsive, some of them actually still had VExUSs of 2, which is a fairly significant congestion. And then the rate of kind of having high congestion is probably even a bit more if you're fluid unresponsive. But what that means is that we can't just say that, oh, the patient is fluid responsive, they're not congested, because there could be this overlap. And I think really having both sides of the equations will help weigh the risks and benefits of IV fluids. So in this patient that had pneumonia, septic shock, they'd had 3 liters of fluid, we look at their hepatic vein here. And so this is our A wave, our S, and our D. And normally S should be much greater than the D wave, but these are kind of equivalent. So that's probably a patient with a little bit of congestion. We look at the portal vein and we notice that there's pulsatility here, maybe 30, 40%. So again, not totally normal. And then we look at the kidney, and the kidney really cinches it. This is a biphasic pattern with pretty significant interruptions in flow between the different beats here. And so the question is why? And so this is where I want to kind of push this one step further. Does this patient need Lasix? Well, let's first look at their heart here and figure out what's going on. So when we look at their heart, what we see is that the RV is severely dysfunctional, severely dilated. There's evidence of kind of some pressure stuff going on here. The RV kind of in this RVOT view, just like severely dysfunctional free wall. So this patient actually benefited from having inotropes and kind of decongestion via inotropy as opposed to volume, because it wasn't a volume issue for this patient. It was acute RV failure in the context of pneumonia and septic shock. And so really venous congestion is present early in septic shock, up to maybe a fifth of patients. Fluid responsiveness and congestion can actually coexist and probably do in more patients than we think. And that RV failure is really a key contributor to venous congestion. And when I see a patient with venous congestion, I don't think, how much Lasix should I give? I think, all right, what's their RV doing? Because maybe the treatment is an inodilator, is a pulmonary vasodilator, is just kind of supporting the RV from acidosis perspective, or maybe it's fluid removal.
Brilliant. That's an absolutely brilliant case. I think that just shows about the interplay between fluid responsiveness and tolerance. And certainly whenever I was taught to do the whole thing about a straight leg raise and seeing what happens with the blood pressure and various other markers, I always thought that, well, yes, they seem responsive to fluid, but what does that mean on a sort of a more physiological level? And as we can see now with the studies that you've just shown there, they can both coexist. So you need to do a bit more digging to find out what's going on. And then in this case, it was a RV failure, which really scares me. Whenever a patient's got RV failure, it scares me more than when they've got LV failure, for obvious reasons. And it just demonstrates that you need to really delve into doing the echo and various other parts and put it all together, as we talked about, as an extension of your clinical assessment. So this is a really good it's a really good case to showcase that. And what did you say was the cause of the RV failure? Did you say that was a sepsis or?
Yeah, I think that it can be really multifactorial in these patients with pneumonia. The higher afterload for the RV vis-a-vis their kind of pneumonia, hypoxic vasoconstriction, acidosis if they're a bit acidotic, septic cardiomyopathy, fluid, maybe they have kind of vascular disease and they have some low-grade ischemia going on due to their shock state and the hypotension. I find that often in these septic patients, the RV dysfunction that we see early on is somewhat transient. And once you kind of support them in the ICU, their hemodynamics and metabolics get better. The RV failure resolves in the first few days. One of the strongest associations we found in our pilot study was actually between the RV failure and congestion. And in fact, there was a strong relationship between the two. I don't have the exact numbers off the top of my head, but I think about half the patients that had severe congestion had concurrent RV failure as a contributing factor.
Wow, that's really, really interesting. And yeah, that's brilliant. That just showcases as to what's going on. And yeah, I think that's a fascinating case to show what how you need to evaluate the patient further to get a clarification of what's going on. So thank you so much for that. That's great. I can't think of anything else with this case for now. Should we move on to the next one?
Absolutely. So this one's a little bit different here. So this is a patient that's hypotensive, they have fevers, and it's following a lung biopsy like a day or two later. And so despite a few liters of fluid on the ward, they're still hypotensive. And what I want to show you here is actually it's a different thing. This is actually the carotid Doppler and the jugular Doppler kind of interlaid and measured at the same time. And the carotid Doppler here, we can see has a fair bit of variability here, which you could almost equate to something like pulse pressure variation. And then the venous Doppler, which is the jugular venous Doppler, you can see the intensity of it relative to the arterial Doppler is actually quite high. And that can be a marker of elevated kind of venous pressure here. And I'll just kind of point to this for a second. And so this patient, they get an echo done, and there's a large pericardial effusion here. When we look at the mitral valve inflow velocities here, we can see that there's a fair bit of variation. So above kind of 30% is certainly 25-30% is certainly significant. And this was, I think, 40%. And then so one of the clinicians did a pericardiocentesis, and the patient had a purulent pericardial effusion. And so this is, again, before on the top here and after. And what you notice here is that the amount of respiratory variation decreased significantly. So this would be like seeing on the previous slide here, the amount of respiratory variation of your E or inflow velocities decreased. Similarly, the amount of variation in the VTI kind of reduced, but also the ratio between the signal intensity between the venous and the arterial normalized. So this is much more similar to this compared with this, where it's much, much brighter. And so one of the interesting things about this is actually that this kind of demonstrates that that pericardial effusions actually cause venous congestion. So in this case, the venous signal is very, very intense because the pressure is very, very high. But when this normalizes, it suggests that the relative kind of forward flow, backflow kind of normalizes. And that's something that we don't often think of, but pericardial effusions can certainly contribute to venous congestion at the organ level. And I've certainly seen cases of patients with tamponade that before and after doing pericardiocentesis, you have improvement in your renal Doppler, hepatic Doppler, or something along those lines. And so this was from a case report that we published. So I encourage any of the listeners to kind of view that. And then just my take home here is that septic shock does not mean distributive shock. And this is something that I think many of us who do a lot of ultrasound are very familiar with. But if you don't do ultrasound regularly, we often think that, well, like the treatment for septic shock is fluids and vasopressors. Well, if you have septic shock, you can have any etiology of shock you want. You could have RV failure, LV failure. You could have a valvular catastrophe because you have new AI from endocarditis. You can have pulmonary hypertension related RV failure, pericardial effusion. You could be severely hypovolemic because you have a concomitant bleed, or you've been having diarrhea. Really, the world's your oyster if you have septic shock. You can have whatever type you want. And that really, there's multiple ways to detect congestion. So we're talking a lot about venous Doppler, but CVP is a marker of congestion. Does it have the same predictive capacity as VExUS or venous congestion Doppler? No. But is it still valuable? Absolutely. You could use jugular venous Doppler. So you can measure and looking at SD patterns in the jugular vein. You can use VExUS. You can use individual markers of congestion. You could look at just the intrarenal vein or the hepatic vein or portal vein. There's probably some value to having multiple ones to seeing whether or not everything's pointing the same direction. Similar to in clinical medicine, we don't ever just base on one physical exam findings. We integrate the whole physical exam and see which direction it's pointing. I recommend that for venous congestion as well. And then the femoral vein, you can look for femoral vein systolic reversal. And this is something that we've looked at in septic shock as well, and is very, very feasible. And maybe is even an easier way of doing it than venous congestion Doppler. And so these are all areas of future research that certainly our group and many groups kind of around the world are working on. But hopefully, as we have these answers, we can start, we can really find a way that's actually generalizable, because doing VExUS is hard. It's not easy to do at the bedside. It's time consuming. If you have 30, 40 patients in the emergency department that you're looking after, or on a medicine ward, you're not going to be doing VExUS on everyone. So hopefully we can find ways to simplify this such that everyone has access to this information without necessarily having to have the time commitment required.
Okay, that's absolutely brilliant. I think this case is really fascinating, and it opens up more of the possibilities of looking at different aspects of the venous system. And you mentioned that the jugular and femoral as well, which I've come across more recently. It's fascinating that he's doing, and I'm really encouraged with the work you're doing as well, looking at different markers and how that correlates. And I think that's certainly a valid work. And just to go through the cases, case one was a typical sort of heart failure patient who needed a bit more assessment, a bit more careful fluid management, though the creatinine was rising. It was about making a decision of whether you keep going with diuresis, and as you pointed out, it's not just the VExUS, but also the whole clinical picture. But when you put it together, you still kept going with the diuresis, and actually showed that the creatinine started falling. So that was fascinating. And then case number two was about a septic shock patient. Again, as you said, it can cause havoc with various different systems, and it's about realizing that it's not just looking at the VExUS, but also looking at the pump, and realizing that there could be failure there, that you need a much more comprehensive approach with certain vasopressors and certain pressures that you need to adjust. So that's fascinating. And then you went on to talk about how pericardial effusion and tamponade can cause sort of this venous congestion at the cellular level, and that makes complete sense. And it's about bringing it all together at the end and realizing that this is not finished yet. We need a bit more work. We need to realize that how can we make it more accessible, because it will take time to get that competency, and realizing how that correlates with every patient. So hopefully we can, by doing more research, we can find more answers about that. And I think with every research, I'm sure there'll be more questions that will come of it, and that will drive more research. Because it's interesting, sort of in emergency medicine, we've got the RUSH protocol, as you know, for hypertensive patients, but it's a very simple protocol, as it were. It is just a quicker screening at looking at what's causing this shock. But as we know from the literature and clinical work, we know that sepsis and hypovolemia is causing most of the shock. Sometimes you do find interesting pathologies such as pericardial effusion and tamponade in particular, which you didn't think about, and you're like, oh, that's why they are very hypertensive. But I think there is much more to that, because the RUSH protocol is quite accessible, but then again, how do you interpret it, and how does that do you apply it to every single patient, or do you apply it to certain patients? So my first question is, what do you think? How do you think the hypertensive protocol, such as RUSH protocol, sort of can work alongside VExUS score? And is there anything else that we need to add within all that? We talked about the echo, of course. We didn't really talk much about the lungs, but that's sort of that's quite more obvious. So how do you think they can all be brought together?
Yeah, a great question. I think that every ultrasound scan or ultrasound protocol is a tool to answer a specific question. And so for the hypotensive patient, I think that the Rush protocol is a fabulous place to start, and it'll identify the kind of unexpected occult forms of shock. And I think that that's probably 90% of managing a hypotensive patient is, are you in the right bucket of shock? Is this cardiac, hypovolemia, distributive, or obstructive? And if you can get yourself in the right bucket, your treatment is probably 95% of the way there, just empiric treatment. I think that most of the kind of big misses are when we think that we're treating one type of shock. Oh, we're treating septic shock. Septic is distributive, without taking a step back and being like, no, septic shock is not distributive shock. Septic shock can be whatever type of shock it wants. Um, when I think the questions that venous congestion answers are somewhat different. It's not that patient who's arresting in front of you what's going on. It's very much you have that patient with a hemodynamic acute kidney injury of some sort that you're trying to figure out. When you have that patient with a rising creatinine despite diuresis, when you have a patient early on in septic shock with RV failure, with renal failure, and you're trying to figure out, okay, like, is this renal failure congestive or do they need more fluids? These are the sort of questions that are much more kind of, they're not the big, like, heroic save kind of level things. They're the more day-to-day management of the patient. And I think that a lot of the benefit of venous congestion ultrasound can be had by anyone without any POCUS training by just kind of thinking about one thing. And that's really that when we give somebody IV fluids, we're giving them salt water. We're giving them a bag with like 8 tablespoons of salt in it. It's not magic. There's no magical property to IV fluids. Sometimes they get kind of idolized and put on this pedestal because if you watch any TV show, the first thing that happens when the patient's coding is, I need an IV stat, and then somebody's squeezing the bag. But that's just Hollywood. We have to be realistic about the potential benefits of IV fluids, which is it's salt water. It might help, it might not. If you take that as kind of your base assumption, say, all right, the cure for everything is not salt water. I'm going to think about the benefits of fluids, but also the harms. That's 99% of it. Because then you're not going to put somebody on maintenance fluids at 250 an hour, which is like 6 liters of fluid a day for no reason. Because that just doesn't make any physiologic sense. You're not going to resuscitate somebody with 25 liters of crystalloid over 24 hours because you think that they're just really dry. Like, that makes no physiologic sense. So if you can start just adapting in our minds that it's salt water, it might help some patients, it could harm people. We need to weigh the risks and the benefits like any other treatment we make in medicine. And one of the tools to measure the harms of fluid is venous congestion. I think that's a really good kind of starting point for most people.
That's absolutely brilliant. I think you hit the nail on the head there. I think one of my passions about fluids, and when I graduated from medical school, I didn't really have a good understanding of what fluid is, how much do I need to prescribe to patients, and it seemed that everybody was like, well, if they're an adult, then prescribe this much if it's for maintenance, and obviously if you're trying to resuscitate them, give this much. And it didn't really make sense to me, and it's one of those where like oxygen, we are prescribing it. Oxygen and fluid is the most prescribed medications, drugs, whatever you want to call it, yet there isn't that appreciation as to what we're trying to do. And as you say, it's that harm that you can cause. And I'm really aware when in emergency department we are giving patients fluids, and what are we doing? Yes, we might not see that harm right away. However, down the line, if they're going to medical wards or critical care, then our colleagues need to deal with that. I think oftentimes septic shock is a good one, because oftentimes the patient is still hypertensive. We've given them 3 liters of fluid. You call an intensivist and they're sort of tied up somewhere, and they'll be like, yeah, keep going with fluids. And if you end up giving them 5-6 liters of fluids, the blood pressure is still not picking up. They might be producing a small amount of urine. And then you're thinking that, well, I'm not sure if in Canada you use metronidazole, so you're thinking of, well, do I start metronidazole infusion? But then again, it's you don't really appreciate what's causing that. But I think it's about yes, it's about sort of balancing that benefits and harm and trying to kind of find out what you're trying to do and use the different measures. So no, that's brilliant. So yeah, the Roche protocol is more with sort of the big saves, and the venous congestion is more to do with more sort of subtler, um, looking at the cellular level, looking at the organ level, and trying to get an understanding of, what am I trying to do here? And then to open it out, you're looking at the heart in much more details, aren't you? It's not just a case of looking at it. Well, I suppose you do, as you showed with case two, as it were. You showed that you can clearly see that the RV is not contracting very well. You don't need to start sort of measuring TAPSE and various other measures to get an understanding. You can clearly see that it's not functioning well, which always scares me. If you look at a right ventricle and it's not functioning, and I'm like, oh God, this patient already has a poor prognosis. In my mind, but doesn't have to. You can sort of treat them by our intensivist colleagues such as yourself. So no, that's fascinating. So I suppose now going forward, you alluded to it in case three. Going forward, how we can take this work forward. So what are your thoughts? How do you see VExUS developing more in the future, and what are the sort of the research that we need to do?
Yeah, good question. I think the first thing is we have to definitively establish the association between congestion and patient-important outcomes in some more populations, particularly septic shock. It's been shown in the cardiac surgical population, the cardiology population, patients with congestion have worse outcomes. We just need to demonstrate that in some other populations to start. The next thing is, now that we've identified this association, is there actually a causal effect of some sort? Is venous congestion causing organ dysfunction, or is venous congestion just a marker of a sicker patient that would develop organ dysfunction regardless? And is venous congestion something that can be intervened on through decongestion, through fluid restrictive strategy, through inotropes, through pulmonary vasodilators to improve the outcome? That's a big question. And there are protocols that are looking at that now in cardiology, for example, cardiorenal acute kidney injury. Can we decongest patients following VExUS, and does that improve outcomes compared with just empiric kind of decongestion? We have funding to do that in septic shock as well. Can we use VExUS as an early marker in like a controlled trial to guide decongestion? And that's something that we're going to be looking at. So I think we're getting ready, but I think we need to answer those questions initially.
No, yeah, that's a very, very good point. And it's about, as you say, can you intervene with any of those? It's great to sort of be able to measure these, but how can you intervene, and how can you then keep monitoring the progress, and is it getting better? And it's a bit like the chicken or the egg. And is just trying to get an understanding of what we can do. So I'm not quite sure if you came across a paper called the title is includes Fusic hemodynamics, the Fusic HD. This is a protocol that has been proposed in the UK, and it includes VExUS, but as a part of that protocol, there are other aspects. So you look at the heart in very close details, and you do various different measurements, quite sort of advanced echo things, and it makes it even more daunting to be able to learn all that. And my initial reaction was, I'm not quite sure if you're even ready to sort of take that leap of saying that, well, we're going to be putting it all together, and VExUS is already, as you said, sort of it requires, certainly when I try to do it, it can be challenging, and ideally you need to have the ECG leads there to be able to recognize which where you are within the cardiac cycle. But then on top of that, if you add the sort of very advanced echo and various other things, then all of a sudden you end up with a protocol which is already too complicated, and I'm not quite sure if you're ready for that. And I think we're already finding that that's challenging to implement, and to then give that to the sort of to the learners, it's going to be a very niche population of trainees or trainers or whatever you want to call it, who would take that up. So it's interesting. I think yeah, we just need to see where this goes. It's fascinating. I'm not an intensivist, but I'm very interested in POCUS, and I'm getting more and more interested in venous congestion and various other cardiac scanning, and I think that this will play a really important part within all that. I'm really looking forward to see your studies coming out. I know that you also have a website, haven't you, that looks at using AI and collaboration with various different experts within the field to try to make research more accessible and easier to do. So that's quite fascinating as well. And I hope that more and more people will join that. So do you want to talk a bit about that as well? Your website.
Yeah, absolutely. So it's a project that we launched a few months ago. It's very early on in its stage, and admittedly, we're not entirely sure where it's going to end up. But the idea is that we want to make research, performing research kind of efficient, perform high quality research as the default, and help researchers have an impact. So the website simplesage.io, and we're kind of building some tools there, and we might have kind of some spin-off projects coming up, and yeah, I'll keep you posted on it. But it's just been a fun way to kind of flex a different side of the brain and developing kind of software tools that researchers and clinicians would find useful. So yeah, it's just been a ton of fun.
Okay, thank you so much. I think, yeah, that seems really exciting. I've seen it. I need to sort of spend a bit more time with the website. But yeah, that's really exciting. And thank you so much for joining us today. And I'm sure this is going to be a really useful talk for our colleagues to view. And I'm sure there'll be more comments and questions coming our way, your way, as it were. And hopefully we can have more talks in the future. If there is nothing else, then we'll bring it to an end. Is there anything else
Great.
you would like to?
No, thanks for having me. And people can connect on Twitter or shoot me an email. Yeah. And
Yeah, brilliant. Thank you so much. Right. Thank you. Cheers.
take care.